Welcome to the Catherine Vandome and Me podcast.
Hashtag hosts and the HQFM quiz and bingo software are proud to sponsor the Catherine Vandome and Me podcast. With HQFM quiz and bingo software, you can use this interactive quiz software at any venue. All you need is an internet connection. Go to hashtagquiz.co.uk for your free trial today.
Hello and welcome to Catherine Vandome and Me. And today I'm joined by an incredible guest who has quite literally saved my life. He is a neuroscientist and osteopath, and he has a PhD in the field of ME, which is myalgic encephalomyelitis. In 1989, he devised a treatment called the Perrin technique, a specialist treatment with a diagnosis for this condition, and he has been treating and diagnosing patients all over the world for 35 years. He is an incredible man. He's also a multiple author, including a book by the very same name called The Perrin Technique by Dr. Raymond Perrin. And inside his book, I am a case study and one of the most toxic poison patients that he's ever treated that has survived. And so I want to personally thank Dr. Perrin for saving my life. It is thanks to him that I am sitting here today. So it's all his fault. And thankfully, he also has appeared inside my book, which is dedicated to him, which is called The Truth About Me. And I really, truly cannot wait to welcome on my guest today, because, as I say, it is thanks to him that I am here. Please welcome Dr. Raymond Perrin. Hello, Ray. How are you?
Hello, Cathy. Thanks very much for having me on your show.
How are you doing today?
I'm okay. I'm just a bit, I was in America, as I think you knew, a couple of weeks ago, so just about getting over jet lag. I don't usually do jet lag, but I was in the States training up people, and I think it was more family holiday that I'm exhausted from afterwards.
Well, that's great. And you are quite well travelled, which is great, because your technique, of course, is something that's available all over the world, and increasingly so today, needed more so than ever before. So I'd like to start. We're going to take you back in time and hear a bit more about you. But I'd like to start today, Ray, by you just explaining a little bit about who you are and your technique, and a little bit of your background.
Right. Okay. So I'm an osteopath by profession. I trained in 1980 to 84 in the British School of Osteopathy in London, which is now the University College of Osteopathy. And in 1984, I came back up north to Manchester, where I grew up, and I set up my first practice here in Manchester. And I was aiming to become a sports osteopath, working with sports injuries and working with certain teams of sport in Manchester. As you know, we're quite sporty up north. And so that's what I wanted to do, and I wanted to make my niche in the sports medicine area. And then in 1989, my life changed forever, and that was when I was treating a member of what was known as the Valley Banana team. It was a bike racing team. And he hadn't been cycling for 7 years because he had ME. And he came to me with back problems. And I said, I can treat your back, but I can't really help your ME. Because in those days, we were taught that ME was a more psychological problem. It was known as yuppie flu in the press. And I thought tender loving care will help him, but not really helping anything else. Little did I realize that when I helped his spinal problems as an osteopath, his symptoms of ME started disappearing.
Wow.
And within a few weeks, he was much better. Within a few months, he was symptom-free. And he said, "You've cured me. I've been everywhere. I had 7 years of ME where I've not been able to ride a bike, and now I can do everything again." And after that, as they say, the rest is history. He came in with a whole pile of sheets about his about ME, and he said, he'd done his own research. He said, "Read this because you found the answer, and now you can work out why." So I did.
Oh my goodness. That's
And that was-
incredible. That is
Yeah.
absolutely incredible for anybody. And I'm sure there's very, very few people who don't know who you are. But for anybody who today is watching today's podcast and hasn't yet had the joy of meeting you or hearing of your work, I think it's absolutely fundamental to the diagnostic and treatment of this health condition. And for anybody who's watching who perhaps has one of the other, like you say, yuppie flu, another name. There seems to be a lot of different names over the years for this condition.
Dr. David Bell in America called it the disease of 1,000 names.
Oh, really?
Yeah. But it was, or other people have said it's a black hole of medicine where everything that they don't understand is put into that category. But
Right,
it's now known as ME/CFS by the community.
Just say that again, Ray, sorry.
ME/CFS. So it's myalgic encephalomyelitis, the myalgic meaning muscle pain, and encephalo meaning the brain's involved somewhere, and myelitis is inflammation of the spine. Now, it's not always inflammation of the spine, so some people call it myelopathy. But then the CFS is chronic fatigue syndrome, is a name that the UK doctors have given it for many years. So as a compromise, NICE guidance, the latest one, calls it ME/CFS.
Right, and what's the other condition that you treat? Obviously, I have fibromyalgia as well and Ehlers-Danlos.
Well,
Would you say
fibromyalgia.
Go on. Yes,
fibromyalgia,
okay.
Ehlers-Danlos, and other conditions. Are we allowed to mention it or not?
Yes, absolutely. Well, today we've got long COVID, Ray,
COVID, yeah.
And it's showing, as I said to Dr. Nigel Spate, there's 100 identical symptoms of ME and long COVID, which seem to overlap.
That's what I was saying in my new book that's coming out at the end of the year on long COVID, and that's going to be called Into the Looking Glass. It's going to be called Through the Looking Glass, I should say. My paper predicting long COVID was published in 2020, and that paper was called Into the Looking Glass. We were predicting that after COVID, there's going to be a post-viral condition, the same as ME, post-viral fatigue, and it's going to hit millions of people around the world, being a pandemic. And now the figures are that there's around 65 million people with long COVID. And I said most of it is ME. And even the leading authorities accept that it's very much an ME type condition. So it's causing the same symptoms, and I believe it's the same pathology, the same what we call pathogenesis behind it, the same build up to having these diseases is all equally the same, and that's based on my theories and my research.
And that's important for me to ask, Ray, what do you believe is the causation in your diagnostics and your peer-reviewed and clinical trial studies? What do you believe is the diagnosis of ME?
Well, the diagnosis is multifactorial, but I mean the cause of it, what we call the etiology, I believe is a buildup of toxins in the brain and the spinal cord. And this buildup of toxins happens because there's a drainage system in the brain and spinal cord. The central nervous system is made up of the brain and the spinal cord. And a lot of people just talk about the brain, but we should always remember that you've got the continuation of the brain, which is similar tissue going right down the spine, the spinal cord. And this area, the central nervous system, gets poisoned, literally poisoned. And there's a drainage system. And the drainage system, when I started working my hypothesis for my research and my PhD, I said that it was the drainage system of the brain that was malfunctioning. And instead of draining out poisons, it was actually pushing poisons back into the system. So that's why I came up with this idea that this was ME was a disease that this drainage system didn't work. However, officially, there was no drainage system of the brain. So I was coming up with doing research in Salford University on a disease that officially most doctors didn't accept existed. That was the ME. Looking at a drainage system that officially, according to medical science, didn't exist. But they gave me a PhD on it.
And when was this, Ray?
Well, my doctorate was in 2005, but I started work in 1994. So it was 11 years of work at the University of Salford. And I published my thesis in 2005.
Wow.
So what I was saying that this drainage system didn't work because this whole drainage system was unknown. It was hypothesized, but I thought, well, it's got to exist. And the rest of the medical world said there isn't. And it all goes back to the lymphatic system. And the lymphatic system is there for the removal of large amounts of fluid. When you have excess fluids in the body, your lymphatics drains it away. If it doesn't, you end up with a condition called lymphedema, where there's a massive amount of fluid buildup. But it's also, it's there to take away the large molecules. Small molecules can go through the blood. The blood has capillaries with a mesh wall where small molecules can go through, but larger molecules can't get in. And that's why we need the lymphatics. The lymphatics have capillaries which allow toxins to come into them. They have valves that open and close, and they allow huge molecules to come in. They squeeze into these spaces and get in. And now the lymphatics then, via a system around the body, drain off toxins eventually into the bloodstream and into the liver. But by that time, they've broken them down a bit. So that's why we need the lymphatic system. However, the brain, according to all medical science, when I was starting my research in 94. So in 1989, I had these ideas formulating after treating this patient. And then over the next few years, I started to think on what I've actually done. Now, initially, I published a paper in 93 saying what I'd done was by treating the spine, I've helped this patient's autonomic nervous system, sympathetic nervous system. The sympathetic nervous system is a system that helps you cope with fear, fight, and flight. Everybody knows about the fear, fight, and flight side, but it's there for everything, really. The sympathetic nervous system monitors a lot of things, and it actually sends messages to all the organs, it sends messages to the blood vessels and the lymphatics. It controls the lymphatics, the sympathetic nervous system. But when I started my research work, I didn't know that. We weren't taught that. We were taught the sympathetics have that the lymphatics have no nervous system connected to it. It's just tubes that are squeezed by blood flow and muscles, but they're just tubes. And we weren't taught about valves, we weren't taught about nerve control, and we definitely were taught that the lymphatics doesn't exist in the brain and the spinal cord. So why were we taught that? Because it's very simple. In the brain, you have a barrier. And the barrier is a blood-brain barrier, stops any large molecules entering the brain. It's a protection. So if large molecules can't get into the brain, you just need the blood to drain off the small toxins and not the big ones, because big ones don't get into the brain or spinal cord. So that idea of the lymphatics wasn't part of my thought process at the beginning, but I knew I was helping this person. And the symptoms seem to be symptoms of sympathetic disturbance. And I by manipulating his spine and by massaging it and relaxing him, I was able to get the sympathetics working better. And that's what I thought I'd done. That's what I thought ME was a problem with the sympathetic nervous system. So I wrote a paper in 93. It was published in the British Osteopathic Journal saying this. And at the same time, there was a doctor in America, Peter Rowe, also formulating his ideas that ME was a form of sympathetic dysfunction as well. So we both came up with the same idea about a similar time. I wrote the paper in 93, which was the first paper saying it was a form of what now is called dysautonomia. But the thing is, I just had part of the picture, because I didn't think about the lymphatics, because the lymphatics, according to my original teaching when I was in college, we were taught there's no connection between the brain and the spinal cord and the sympathetic nervous system. However, osteopathy for the last, it's been around for 150 years, always talked about that there's a connection between the brain and the lymphatics. And Andrew Taylor Still, the founder of osteopathy, and William Gardner Sutherland, who was the founder of cranial osteopathy, was one of his students. They together were talking mainly a lot about in the texts of their books and their papers, talked a lot about the drainage of the brain into lymphatics. However, in the 1960s, electron microscopy proved that the blood-brain barrier was a real thing. It was theorized before there was this barrier, but in the 60s, it was proven that it was. So if there's a barrier stopping any large molecules in, then there's no drainage of the lymph from the brain, because you don't need one. It's very simple.
Right.
The small molecules get in, and it's blood, but large molecules can't get in. So osteopathy changed the way it was teaching. And when I went to college in the 1980s, I was not taught anything about the neurolymphatic system, as I called it, the system of drainage of the brain into lymph. We were not taught that because it was agreed that was nonsense, and science definitely showed there was a blood-brain barrier, and therefore there was no lymphatic system of the brain because we didn't need one. And I did this PhD on this drainage system of the brain that I said was going wrong, even though officially it didn't exist. But I knew it must.
Well, that's incredible. I think that succinctly describes, the backdrop to the science behind why this condition occurred.
The main thing is, why did I know it must? And this gives a big clue to most of the symptoms of ME. And it also gives a major clue to why women get ME much more than men. So I studied physiology when I was studying osteopathy. Yeah. And when we came to a whole area of the body, the hormonal system, what we call the endocrine system, the hormones we were taught were all controlled by an organ in the brain known as the hypothalamus. So you have the famous hypothalamic pituitary adrenal axis affecting the pituitary gland and then controlling the adrenal glands. So, and there's a hypothalamic pituitary thyroid axis, and there's a hypothalamic pituitary, and it goes to all the different endocrine organs in the body, all the hormonal organs, including the pancreas that produces insulin, including in the reproduction system, and there's lots of hormones there. So the whole thing goes right back to the hypothalamus. The hypothalamus is the mother of the hormonal system. And how does it work? How does the hypothalamus control the hormones? It controls it by a mechanism called biofeedback. Hormones enter the brain, and the hypothalamus measures those hormones and sends messages via sometimes other hormonal systems or autonomic nerves like sympathetic nerves, and there's also parasympathetic nerves like the vagus, and they send messages back to the organs and control the rate of hormonal distribution, of hormonal control. And the hypothalamus does this all day long, every day, from the day we're born to the day we die. So then I was thinking, wait a second, hormones are huge molecules. Take the blood-brain barrier is a proper barrier. It's a physical barrier. It's got tight junctions that stop any large molecules getting in. The smallest molecule, like a water molecule, water is in molecular size 18 daltons. Dalton's a measure of a molecule named after John Dalton, who was from Manchester, by the way. We'll wave the Manchester flag. And so 18 daltons is a small molecule of water. It can get through the blood-brain barrier. Larger molecules can't get through. So if you take insulin, for instance, insulin is produced in the pancreas, in the tummy, and it goes up into the bloodstream and then up into the hypothalamus, and the hypothalamus measures the insulin. It's got receptors on it that measure the insulin levels, and then it will send messages via autonomic nerves back to the pancreas to stimulate the production of insulin to keep the body balanced. So if there's too much insulin, it will reduce the insulin production in the pancreas, and vice versa. So it got me thinking. I said, well, if insulin gets into the brain, which it obviously does, how? If there's a barrier stopping it? Because insulin is 5,808 daltons. So water molecules, 18 daltons. Insulin is 5,808 daltons. It's huge, whopping polypeptide molecule, and it shouldn't be able to get into the brain. There's a barrier there. So then I thought, well, obviously this barrier is not very good. There's got to be gaps in this barrier, major gaps. And there are. There's 7 major areas in the brain, 2 in the hypothalamus, in other parts of the brain as well, known as circumventricular organs. And these areas in the brain allow huge molecules of hormones, huge molecules of electrolytes, salts and sugars. Loads of things get through the brain, into the brain, through the blood-brain barrier. So if large molecules like this can get through, so can toxins, huge toxins, viruses or toxins. It's not, you see, I mean, the name post-viral fatigue gives us a clue. It's not the virus or not the bacteria, not the infection that causes the problem. It's the trigger. It's post-viral. So what's happening after the person's had an infection? When you have the body, when you have invaded by what we call an antigen, if you have any molecule that the body doesn't like to be in the body, it will react. So whether it's a bacteria, virus, or mold, or any man-made toxins, and there's plenty of those around, hundreds of over
carbon
100,000.
monoxide, in my case, carbon monoxide.
Yeah, well, carbon monoxide was one of them, but there's many, many more of different things, much more.
Is it 85,000, Ray? Am I quoting that correctly?
Well, no, I think there's around 100,000 now. No.
Oh, okay, that's gone up since I last saw it.
Yeah, I think it's around the 100,000 mark of neurotoxins in the environment that can actually damage us. But those are large molecules that need to be got rid of. So what happens? So let's talk about, say, just a simple bacteria. A bacteria enters the body. Or any infection enters the body. The body will produce chemicals called cytokines. Cytokines are large peptide molecules. They're large protein molecules that attach to the invading organism. and then says to the antibodies, QE, we're here, come and get us. And they're signaling molecules. So the antibodies that you produce in your body to kill these invaders will go along to where the cytokines are attached and attack. Those cytokines afterwards, when the infection's gone, are surplus to requirements. They need to be drained away. So what drains these large molecules away? What should drain away? The lymphatics. So I said that basically the lymphatic system of the brain is working the wrong way, because the sympathetic nervous system that controls these nerves, that we now know does definitely controls the lymphatics, the sympathetic nerves. So we know that the sympathetic nervous system's going wrong. And that was my original hypothesis in the early 90s. But why did it go wrong? Because the toxins are building up in the brain to make it go wrong. Because what controls the whole of the autonomic nervous system is the hypothalamus. And that's the area most likely to be attacked by toxins, because it's got two of these major windows through the blood-brain barrier. So when you get infected, it's not the virus or bacteria or anything like that. It's the cytokines that you produce to get rid of them, that aren't to signal to the antibodies that aren't being drained away. And the debris from the dead molecules of dead viruses, dead bacteria, aren't being drained away at all either. And they can be toxic as well.
If I can just interject and ask about heavy metals and all the other toxic, pesticides, all the other poisons that we're exposed to, would you say that also creates a cytokine storm?
Not a cytokine storm. They themselves are toxic.
Okay.
So the heavy metals and all these are major causes of toxicity. The body needs to get rid of them, but it's not so much cytokines that they produce. The body produces cytokines, but it's not the heavy metals or these neurotoxins. They themselves are damaging to the body. They take over the nervous system and they stop the nervous system working, and they cause dysfunction themselves. The chemicals that we pump into our bodies, from outside, a lot of them actually damage the body's natural metabolism, natural systems. You don't need the cytokines would come along anyway, because there's inflammation. There's a lot of buildup of cytokines, but it's not. It's more the cytokines are there for infections, for the body's immune system to respond, and also in stress. Stress creates a lot of cytokine activity as well. Allergies creates a lot of cytokine. Allergies, if you're
like
allergic
hay
to
fever,
things,
asthma, that kind of thing.
Yeah, because you have mast cells that produce a lot of the cytokines are produced by cells in the body called mast cells that are found everywhere, including the brain. And you have a lot what we call now mast cell activation syndrome happening, whereas these mast cells get overloaded, and a massive amount of people have this mast cell activation. And we've known about this in the days of just ME, and now with long COVID, a lot of doctors are talking about mast cell activation
and
syndrome.
That's something I've got, Ray. I think it's important so that the person that's listening today can listen to some of my symptomology and diagnostics from yourself, and also empathize and with their own condition and see similarities. So that's something that I have. I can't wear makeup now or go near chemicals because I flare, don't I?
Yeah, because those mast cells produce histamine, which is damaging, but also stimulate the production of cytokines and also other chemicals called prostaglandins that create a lot of inflammation. Inflammation is the body's way of dealing with problems. Inflammation is a way of healing. It's an inflammatory process is important for healing. You need cytokine production. You need all these things to help the body repair. However, if there's too much of them, too many cytokines, too many prostaglandins, too much histamine, it's going to overload the system, and then the cytokines will attach to healthy cells. And when they attach to healthy cells, your antibodies attack the healthy cells. And that's what causes what we call autoimmune diseases. And that ME and long COVID and all these conditions have a part of their illness is very similar to many autoimmune diseases because of this. And we see this again and again, and all the science backs up what I've been saying for years. And it was, I said all about this then, and I said the toxins need to be drained away. The cytokines need to be drained away afterwards. There has to be a lymphatic system in the vein.
Yeah.
And I said this in my work early on in the 90s. And it was my thesis was published in 2005, and I had to wait for 12 years before research has now proven, in 2017, that what they call the lymphatic system of the glial cells in the vein, certain type of cells in the vein. So this is the drainage of the vein, actually exists in humans. So I had to wait till the technology came around that we could scan the vein and see this for the first time. And that was in 2017.
And you predicted this. You predicted this in 1996.
In the early 90s. I formulated my ideas after. In 1989, I helped my first ME patient, and then during the early 90s, I formulated the ideas of what I was doing. And then I realised about the lymphatic system was involved. It just went further. And when I started my research work in 94 in the University of Salford, this was my hypothesis.
My goodness. So would you say that you were the pioneer? Is everybody now, scientists all over the world, desperate, reading through literature and saying, hang on, let's find this Dr. Raymond Perrin. He was bang on the money.
Well, the thing is, I wasn't the first person who said there was a drainage system of the vein. In the 1800s, there was William Cruikshank, a famous Scottish surgeon who was talking about the drainage of the vein. Then Andrew Taylor Still and William Garner Sutherland, the pioneer osteopaths, they were talking about the drainage of the vein. Speransky was a Russian scientist in the 50s, and the 40s and 50s. He did research in I think it was 1940s. He did research on the drainage of the vein, and there was, and then there's Professor Roy Weller talking about the drainage of the vein. He did research in mice and rats and rabbits and sheep, but they didn't do it on humans because you couldn't just take it. We didn't have technology to do this, and there was no proof. It was all theory until scanning techniques were developed to actually see this drainage, and that was in 2017. And that was in America, and they proved that the lymphatic system of the vein, what I call the neurolymphatic system, what's now known as the lymphatic system, existed.
And how did they prove it existed, Ray? How did they prove it
with scanning techniques that.
And I believe they put some fluid in, just to explain to the audience how
it's enhanced. They did enhanced MR scanning, and they did the original scans were done with a thing called with a fluid called dual photon emission tomography, which was a new technique that was developed in 2012. So that was a group of scientists in Rochester University who showed it first on mice. And this was a dual photon emission tomography, new technology that was developed, and they were able to show the drainage of the vein for the first time in mice. Then it took a few more years to develop techniques they could do on humans that were safe. But the thing is, they're safe on a healthy human. So it showed that a healthy woman, I think she was 47-year-old woman, showed the drainage of her vein. But we can't just do the same techniques on ME patients because they have to put dyes in, and the dyes could be toxic and make the patient much worse. So we can't do that. we have to find other ways, which we are looking at. And if you
Yeah.
once you find that, if you find healthy people and ME patients, or ME patients and other diseases, and ME patients have different drainage system, then it's proven my work. And we haven't done that yet because we haven't got techniques to do this. We're looking into it. New research.
And as soon as that happens, Ray, you can retire. Is that right?
Well, I can never retire. My patients like you won't let me retire, but yeah, I mean, we'll look at other things. But no, what we have shown is that there's we talked about in the earliest part where you mentioned about diagnosis. With my ideas, with my concepts of what's going on with ME, I said, well, if the lymphatics is not working properly, there must be signs of it that we can see.
Yeah.
And there are physical signs that I can not just see, but feel. And we're looking at inflammation of the spine. We can feel heat in the spine in many patients. There's problems in the drainage of the spine. We can see there's the spine in ME patients is never the normal shape. There's always a problem.
Well, that's what I wanted to ask, Ray, as well. I wanted to ask on your diagnostic, because you've got diagnostic studies. I wanted to ask, what is it that you actually see? So that anybody that is either a parent or a patient or has a child with this condition, what is it that you look for when a patient comes to see you?
Right. So we go through a history, of course, and we go through this all the symptoms, and there's a whole group of symptoms. We have 50 symptoms we go through, and there's more than that. And then we work out if the patient's had any trauma in the past, because I said it's not the virus or the bacteria or the fungal infection or
the chemicals
or the carbon monoxide or anything else. It's not that. That's the cause. Those are the triggers. What you do is you look back and you think of all the things that have gone on before. It's a build-up. So your body can cope with toxins to a certain level. Eventually, when the toxins are building up too much, then there's a problem. So what's happening with an ME patient is that they might be born with a problem to begin with. It could stem from birth, from a drainage system in the brain and the spine, from trauma. They could have had a major birth trauma, or later on in life, they could have had major injuries on their heads and their spine.
Just to interject there so that the audience can understand. So a major birth trauma would be what, Ray? Obviously, in reflection to myself, I was
major birth trauma can be if you're born with fontus or forceps. If there's a very great delay, we see a lot of firstborn patients who have had very great delays in being born, so they're stuck for a long time, and then sometimes they're dragged out by forceps, or they've
I was a fast breech birth, so that was significant.
Or the opposite, they can be very fast. And very fast births can sometimes cause major trauma to the head as it comes out very quick. So there's lots, and breech can cause other things. So there's lots of different areas. Even cesarean section, you think, oh, it's not traumatic for the baby, but it can be. But then there's injuries afterwards, which are what we're looking for. There's trauma, head traumas, and neck traumas, spinal traumas. And we see this again and again and again in patients with ME, that they've had problems in the past.
And that could be, for example, a car crash. I had a couple of car crashes. I had my nose broken in childhood. Is it significant, Ray, that somebody could have a head trauma before they are, let's say, age 15, 16? Is that quite significant?
Absolutely. No, it's significant as you're developing, especially I said the nose trauma, because the main drainage of the brain, in my original hypothesis, was a bone, which if I put a hole through my head around there, go in, you come to a bone called the ethmoid bone. And that, in the ethmoid bone, there's a small area called the cribriform plate. And this cribriform plate has perforations in. And the perforations allow the olfactory nerves, the nerves that control smell, to come through into the nose from the brain. And that, my original hypothesis was that the fluid around the blood vessels that supply these nerves was the main drainage of the brain. And you have 12 pairs of cranial nerves in your body, in your head, and the olfactory is just one of them. There's as I said, there's 11 other pairs, including the vagus. And but the main drainage of the brain was hypothesized and been researched by other scientists before me, was looking at the cruciform plate, the olfactory, the optic pathway, the trigeminals in the face, and the auditory. And there lies a big collection of symptoms that people have. They feel very tight in their nose, and they have problems in their sinuses. They have maybe problems in their mouths. They have their hearing might be affected. Their eyesight might be affected. And this is because all the drainage system of the brain drains through these nerve pathways more than any other.
And I think
Now,
I want to
yeah.
just explain to the audience as well. I had my jaw was very much out of line, so misaligned, and that
Yeah.
seems to be quite prevalent. And
Yeah.
that then consequently for me personally, I got vestibular damage.
Yeah.
So
I've
how is
worked a
that
lot with
connected?
dentists over the years who have worked with looking at TMJ, temporomandibular joint problems, jaw problems. And so some of the people I've worked with over the years have been dentists in that specialist field. But going back to the drainage, is that these are the main areas of drainage. But every nerve has these blood vessels next to them and these perivascular spaces around which drain off the toxins. Now there's down the spine as well. So if they're not working properly, this is where you're going to get symptoms. So you're going to get symptoms there, but are there any signs? Well, if the lymph is not draining properly, it's going to congest. Now, we didn't see much lymphedema where there's a cessation of lymph. If the lymph stops working completely and the fluid will build up, you get lymphedema. But we didn't see this. We saw especially in the neck and the chest, and particularly the chest, because this is the main drainage of the lymph goes into underneath the collarbones around here, more in the left side than the right. But the breast tissue, if there's a drainage problem, it will drain backwards instead of up into the bloodstream. It will drain backwards. So when I examined the breast tissue of the patients, that's young, old, male, female, all had lumps and bumps when I felt them under the skin. And you know about that because you have yourself. And these lumps and bumps were just very strange. I thought, what are they? I couldn't see them. I could feel them. So there weren't varicose veins, because if there were varicose veins, they would be bobbly, but you'd be bluish, like varicose veins. So it wasn't the veins I was feeling, but I was feeling vessels. So it had to be lymph.
Yeah.
And I thought varicose lymph. And Professor John Kinmont, who did a lot of work on the lymphatics in the 70s, 60s, 70s, and 80s, he was a professor in London, and he talked about megalymphatics, varicose megalymphatics, huge lymph vessels that he as a surgeon saw that were draining the wrong, were stop draining or draining the wrong way, caused them to be beaded and very large. Now, I was feeling very large vessels, about half a centimetre wide, all around there. That's 5 millimetres in width, all around the chest and the neck.
And
I
in
thought,
my
what
case,
are they?
upper thigh, I want to just add.
Yeah. Oh, yeah. You're the whole body. Your whole body, Cathy. Yeah. But this is the first. But this is the first port of call. If you think the first port of call is going to be in this area, then it can spread out. But I thought if it's lymph, one thing is lymph. The vessel, the fluid in lymph called lymph is colourless. So it would be colourless, and it was colourless. We couldn't see it, but we could feel it. And then, but I could never prove it until I took a photo of one. And eventually a patient came in and he had these massive varicose lymphatics, and you could actually see them. And I took the photo that was in my books and in my papers and in my thesis. But those varicose megalymphatics that we were seeing, the most important thing about it is they were huge. The normal lymphatic vessels under the skin should be 0.5 millimetre wide. And these were 0.5 centimetre wide. So these are 10 times the width of normal lymphatic vessels. And so it was crazy, but this is what Kimmel said he saw, and nobody could believe him, because when he took scans, they thought it was just showing veins, but this was real. And I was able to take a photo of this one patient that then went round the world. And I'll never forget when I showed it at a medical conference, this professor from America came over to me and he said, "Gee, that amazing image. What did you use to get this incredible image? What machine?" I said, "A camera."
Wow. Well,
So,
I know from firsthand, it just shows, doesn't it, that you knew that that was a possibility and you found it. Yeah.
so these backflow, there's also tender points. One's called famously now Perrin's point, because I discovered it. And that was a tender point in the chest that was more tender than anywhere else. And there's also the abdomen. There's a tender point there. So there's spinal problems that we see. There's redness, there's heat, there's shapes of spine problems. There's the varicose megalymphatics, as I call them. And then there's the Perrin's point is a tender point in the chest, and a tender point in the abdomen is another one. And then there's and these are due to irritation of certain nerves, sympathetic nerves, that will lead to sensitivities by a crossover mechanism. So sympathetics can irritate sensory nerves and then cause pain. So
and what I'm just to interject there, what I'm asking as well is, you say a spine and cranium abnormality. It has to. Am I right? It has to be both. So just explain.
The cranium. So the fifth sign that we're looking for: the spine, the varicose megalymphatics, the Perrin's point, the abdominal tenderness, which is called the celiac plexus, the solar plexus. That's tender, and then we're looking at the head itself. The head, osteopaths have for years talked about the cranial rhythm. And recently I said I was in the States and I was talking about my work on the cranial, and we published a paper with the physical signs in that we did research in an NHS. And we had the paper published in the British Medical Journal mentioning what osteopaths have called for years the cranial rhythmic impulse. And in America, one of the osteopaths I taught there, osteopathic physicians, he said he was just amazed that cranial rhythmic impulse was mentioned in the British Medical Journal. That was the most amazing thing. But the cranial rhythm, what is it? And with my work, I came up with a hypothesis that I published in 2007 in the Journal of the American Osteopathic Association. And they made it front page. They did a big headline of it. And I said that the cranial rhythm is this drainage system from the brain, is the neurolymphatic system. So how did I get to that? Well, the rhythm is produced by two other rhythms. Cranial rhythm is about 8 to 12 beats a minute. And I'm exaggerating, but when you feel the head, it's like a concert. It's like a concert. It's like a symphony, and it should move in a very gradual way. It should move, opening and closing around to 8 to 12 beats a minute. That's
now let me just explain that to people. The shape of the skull you're saying can affect that. So the shape of the spine and the shape of the skull. So I have a flat upper thoracic spine, and I also have Ehlers-Danlos. So all my joints are hypermobile and perhaps uber misshapen, which is great for getting in a magic box, but not very good for longevity of the drainage. And what you're saying is I also had a misaligned jaw and a broken nose. These are the structural issues which then led to inner ear damage. And what I want to say in support of you is that one day after multiple treatments, I could feel a fluid drainage in the skull. And you said only the most severe patients can actually feel the fluid.
Patients with ME, when the drainage isn't working, when we get it working again, then they can feel it. So it's usually in more severe cases when they can't feel much going on at all. And with you, when I felt your head, there wasn't hardly any movement at all.
So just to explain that more clearly, because of the shape of my skull and the spine, what you managed to do was, with using osteopathy, was to realigned the jaw, and my teeth were actually in line. And my dentist commented for the first time, my NHS dentist commented that they couldn't believe that my teeth were actually in line. They had never been in line on a scan, and that was all praise and thanks to you. So you realigned the jaw, which opened up the tubes inside the ears, which were constricted. And in doing so, as you say, with your technique, you also did other advantageous things, which we'll go on to. But most importantly, you're saying in ME patients, there is a structural abnormality causing a constriction of the drainage of the actual lymphatic system, which preludes every single ME patient case. Is that correct?
Yes.
Okay.
Basically, yeah, in a nutshell. Yeah. So there's the drainage, but the cranial rhythm is a very misunderstood phenomenon. I wrote the paper that put the science behind it and said that it's very logical what we have. We're feeling this rhythm, 8 to 12 beats a minute, but what is it? And when you look at the fluid in the brain, it's cerebrospinal fluid is produced by blood, and it goes round the brain and eventually gets drained off into the bloodstream. That's what we thought anyway.
Yeah.
But that would lead to the rhythm in the brain moving at the same rhythm as the heart, which is 50 to 100 beats a minute. That's the rhythm of the heart. So 50 to 100 beats a minute we know that's what lives inside the brain. But when it comes out down into the lymphatics, which we now have proof that it does. When I wrote this paper, this was in 2007, there was no proof of that actually happening at all. But it was my ideas. But now we know it actually does drain. But when it does, the 50 to 100 beats a minute drains into lymphatics. And John Kinmont, this professor who did a lot of research, as I said, into lymphatics years ago, showed, besides showing about varicose lymph, talking about varicose lymph, he showed that the main duct of the lymph, the thoracic duct, pumps. And we now know through his work that every single part of the lymphatic system has a neurological connection. Well, virtually every. The capillaries don't actually have nerves attached, but all the collectors do. And there's a pumping mechanism going on all the time. But the main pump is the thoracic duct pumping out into the bloodstream, and that has around 4 beats a minute. When you have 50 to 100 beats a minute draining into another system that has 4 beats a minute, it's going to produce a third wave. It's called in physics the interference wave. So you've got a very fast wave and a very slow wave. They crush together, they can produce this third wave. Now, you don't have to be a physicist to understand this. You just have been to a beach. And the beach have a big wave coming in, small wave going out. They crash together and produce this third wave. This third wave in the brain, in the body, is the cranial rhythm. That's what I said. And this is the cranial rhythmic impulse, around 8 to 12 beats a minute. We had work done at the University of Manchester's Department of Hydrodynamics, who then worked out the figures. And they said, yes, 8 to 12 beats a minute is a very realistic figure for this cranial rhythm. So it's been validated by science. And we published this, I published this in the Journal of the American Osteopathic Association in 2007. So this is now, and this we used this paper to validate what we're doing for the future. And that's why it was eventually, when we showed the diagnostic signs, we found that all patients with ME, the cranial rhythmic impulse, was dampened, was not working properly, wasn't vitality, it was dysfunctional. So we said this in the paper that was published in the BMJ, British Medical Journal, and that's what caused quite a stir around the world, where we had it on Sky News, and we showed that these physical signs were real. When we did the research and showed that the physical signs were all there, the 5 physical signs, we found that only 2 really were necessary. That was spinal problems and tenderness in the tummy, the celiac plexus. But all the signs were there. In the study, we showed this, and it was published in the BMJ, and it was the first study to show the physical signs of ME. And so we're going further with this, with larger research projects eventually. But it's put as it's now made people realize that ME is not just a problem in the mind, it's in the body, it's very physical, it's very real. And that's what we're seeing, the same physical signs, but with knobs on, as they say, in fibromyalgia, where there's lots more pain. And we're seeing the same in long COVID, and we're seeing the same in other conditions as well.
So what I'm hearing you say is that ME is not a psychological condition, it is a physiological condition.
Yeah, definitely not psychological. There's a psychological element to it because some of the poisons build up in the what's known as the limbic system, which is the emotional side of your brain. So it's going to affect your emotions, it's going to affect your psyche. And so we need to sometimes work on that, and some people need more than just what I do.
And that could open a question, not an answer, but could open a question to if toxins can get into the part of the brain that controls the psychological responses, then could it be that psychological conditions, multiple, could also be connected to toxicity in that part of the brain? Is that a possibility?
Yes.
Good question to ask.
Yeah.
I think it's one of the first questions I asked you 9 years ago when you started treating. I do want the audience to hear today that I have been having treatment with Dr. Perrin. I found you in 2016, and thank goodness. And as you said, my cranial rhythm was incredibly tight. It wasn't hardly moving at all. And you have managed to get that fluid moving, and obviously all the hybrid of symptoms. I had 99 of the 100 symptoms. I worked it out one day. The only one I didn't have was depression, and I want you to tell the audience that there is a subset of people with secondary depression, secondary anxiety, but I was misdiagnosed with anxiety because the right side of my body was tremoring non-stop. And I kind of would love you to explain that Cathy Vandome is not depressed.
No. Well, the thing is that most ME patients, depressed patients, they feel they haven't got motivation, they lose their motivation. And the more they push themselves, the better they are. With ME, it's the opposite. They're very highly motivated people like yourself. And the more they push themselves, the worse they get. And this is the post-exertion malaise is a very important part of the picture with ME, but you do get depressed, and my name for it is TPOS. Can we tell people what it stands for? As
long as you block the swear word out. Oh, you can say it. Go on.
Totally.
No, thoroughly.
Or is it thoroughly pissed off syndrome?
I know your own words.
So is it? I thought it was totally. But anyway, thoroughly pissed off syndrome. But
thoroughly peed off syndrome.
Yeah. Thoroughly peed off syndrome. If we want to cut the swear word. But I've a bleep.
So yeah, what you're saying is we are, and as I say, I want to sort of highlight that today as my doctor of this condition. Would you agree that in my personal case, I didn't have anxiety because I worked on stage for a living? I jumped off the front of the stage as Jessie J into the army barrack arms. So there's no way that I had anxiety, and I didn't have depression because I then wrote a book over the next 8 years of the 9 in treatment with you. So would you agree that those weren't symptoms that I, had?
No, you didn't have clinical depression. And unfortunately, lots of people, especially in the 80s and 90s, were diagnosed.
Misdiagnosed.
Well, they were diagnosed as ME, and then they're on their medical notes in the UK, they were put down they had depression.
until 2021 came along. And after the 2021 NICE guidelines were changed to physiological, not psychological, which is what my book's about,
Yeah.
then now the system is a little different. But getting back to you, Ray, I do want to ask this question. When you first sort of started having thoughts about doing this type of work, I would like now to go back in time, so a bit like the Scooby-Doo. And I want to go back in time to you. I also want to take this opportunity to introduce Tinker to you, that he's sat here on each podcast and he gives a little wave each time. So say hello to
I've
Dr.
seen
Raymond.
Tinker. Hello, I've seen you before.
You've met this wonderful man.
I've met Tinker.
And thank you very much. So Tinker's watching you as well today. And on that happy note, I want to take you back in time, Ray, right back to your childhood. And I want to ask you, what was it that started you off with this wealth of scientific understanding of this health condition, and a pioneer in this subject as well? What was it that started you off as a youngster? And first of all, were your parents' influences as well in that decision?
Yeah. Well, my first love was animals. I used to read James Herriot books and read Gerald Durrell books. And
he's listening to this bit.
And I wanted to be a vet. Traveling the world, maybe going a vet of a safari park or something. But I just loved animals, and I wanted to do that. But I went to a vet's practice when I was doing my O levels at the time, and I worked with him saw what he did, and had some clinical practice there to see if it was suited. And he was a town vet that spent most of the time putting down unwanted animals. Close Tinker's ears to this. And I said to him, "That's all you're doing is putting down dogs all day." He says, "That's what we do." And I said, "Well, how can you do it if you love animals?" He says, and he said something very interesting. He said, if you like animals, become a vet. If you love animals, don't.
Did he?
Yeah. So he said, there's so many things we have to do which not in the animal's best interest, but society's best interest and the owner's best interest, but not the animals. So I thought long and hard, and I decided that wasn't for me. So then I was looking at different things. I wanted to do something in the medical profession, and my father used to go to a famous osteopath when he lived in London. Dad, I was brought up till 3 in London, but my dad was a Cockney, born and bred in London, and so he used to go and visit this osteopath. He used to go over the top about Dr. Grumbaum, this famous London osteopath, and eventually, so we all heard about it. And then when I was thinking about what to do, my headmaster, Mr. Pink, he said to me, "What about osteopathy?" And I thought, Dad mentioned that, but Dr. Grumbaum was a doctor. See, he was a doctor from Czech Republic, and he was a refugee. He was a refugee at the time of the war, before the war, when Hitler came in. Obviously, he wasn't allowed to stay there. He managed to escape before the Nazis got him. He was a Jewish doctor who came over to London and practiced in London, wanted to practice as a doctor, but they didn't recognise his Czech degree. So he had to retrain. So he retrained as an osteopath. But I always knew Dr. Grumbaum was a doctor, and I thought, 5 years medicine and then another few years osteopathy. How long do I want to study for? No, it's not for me. I would, I could never imagine studying for more than 4 or 5 years anyway. And look at me now.
I know. I was going to say, look what happened next.
Yeah, I know. I did after 4 years osteo. So then he mentioned that the British School of Osteopathy, you don't need to become a doctor for that. You can just go there, and it's a 4-year course. And so I went and studied in London doing my 4-year course. And then afterwards, I then did 11 years at University of Salford, and I've been carrying on now. I did 2 years before that. I was actually studying theology and rabbinical studies, which was expected of me as I was brought up an Orthodox Jewish boy. So I went to study in rabbinical college. And it was at the Rabbinical College of America in Morristown, New Jersey, where you had to sit and study all day, every day. That's what they're doing. It's like a seminary. It's like a monastery in a way. I found sitting and studying very difficult when I was in school. I just did the bare minimum. I used to tell my boys, I used to sit in the back of the glass room reading my comics and eating licorice torpedoes. So,
well, you've obviously got the brain to be able to do that, Ray. Let's encourage the youth of today. Let's encourage them to study hard to become like you.
do not do that. But no, but then when I went to the rabbinical college, it trained my mind to sit down and actually study.
Yeah.
So when I went to the School of Osteopathy to study osteopathy, it was amazing. It was great. It was easy. I just read through all the stuff I'd done that day and prepared for the next day. And I was quite studious, quite a SWAT, unfortunately. Yeah. Anyway, so I did well in college, and then when I came out, eventually, I said, after seeing this patient in 1989, I decided to go back into college and do research work. And I said,
well, what you did was you went, you were doing osteopathy, and what I admire about what you're saying is you did say, had an osteopath met a neuroscientist before you did the two, then your discovery may have been prior to yours.
Well, yeah, I mean, Andrew Taylor Still was a doctor in the Union Army in the American Civil War, which is about the time he started. And he started in 1874. So he started osteopathy then, and he was so then a bit later was the American Civil War, and he was a Union Army doctor. So he had his ideas formulating. And then there was another Union Army doctor called Jacob Mendes da Costa, and doctor from Philadelphia. And Dr. da Costa saw patients, soldiers, coming down with problems in the heart, but also fatigue, concentration problems. It was called irritable heart disease, or soldier's heart, or da Costa syndrome. But he looked at the physical side, and he said it was a physical overstrain and probably emotional overstrain and possibly chemical overstrain. Being soldiers, they were under a lot of pressure, physical, medical, chemical, and emotional. And then he came up with this idea, and he called it da Costa syndrome. And he said it was mostly the physical side, but the psychologists of the time and the future and later on usurped his ideas, and now Jacob Mendes da Costa is known as the father of post-traumatic stress disorder. So they've taken what he was saying as the physical side and turned it around and made it like it was all emotional side of being a soldier. But if he had his ideas and he was in the Union Army, if he had met Andrew Taylor Still at the same time, they would have put their ideas together and possibly.
But there would have been no Ray Perrin.
And well, there'd been a Ray Perrin, but he wouldn't have been doing research into this because it would all been done already.
I was just going to say, but the great thing is then that their loss of meeting each other is our gain of meeting you, and that's so important as well. And
thank you.
No, it's you're not just an osteopath, you're not just a neuroscientist, you're a humanitarian. You at the forefront of your work, and from the day I met you, you care deeply, like you do about animals. You care about humanity, you care about saving lives. And what I love about you is you allow people like myself as an entertainer to ask you questions. So you allow people to ask questions, and you have an answer to everything that we ask. You have an answer to everything. You actually have a narrative and an answer to many of these questions. And your patients with ME, they have often been so, like I was, so rejected, so cast aside, dismissed as psychosomatic. I mean, I remember trying to get out of a wheelchair to run, never mind walk, because the determination was there, but I couldn't physically get out and I fell on my face. So I tried all of the modalities that were offered at the time. And when I met you, it just made sense. You made perfect sense.
Well, I think that's what most people say. And I always quote Thomas Huxley, who said, famous scientist, who said, science is nothing but organized common sense.
I just wanted to ask you, basically, Ray, what you're saying is you compiled the osteopathy with the neuroscience. You wanted to take it further, so you did, and you studied hard, and you continue to study. And so you've had multiple papers in multiple different, multiple publications, including the BMJ Open, which was for your diagnostic of the condition. Yeah. And what else have you done? Because I know in 2007 you actually went to on the Gibson inquiry to Parliament. Just tell us a little bit about that, Ray.
Was it 2007 or 6? I can't remember. But anyway, whenever the Gibson inquiry was, yeah, that was interesting. That was the government inquiry into ME, and I was invited down twice by Ian Gibson at the time, who was the chair of the committee, to talk about my work, and they were very interested in the diagnostics, and they said that it should be they should look into it for NHS because it was a cost-effective way of diagnosing using the physical science. And we're very highly praised of it. I went down there with the chair we have a charity called the For Me Trust, and the chair at the time, Steve Briggs, came down with me to London. And it was a way of telling the government and all-party commission about my work, and that was quite a long time ago now. And they said that it should be part of the mainstream, but it's not happened yet, unfortunately.
And then what happened? You can tell the story. What happened when you met me?
When I met you, my life changed forever.
What did we do? Go on.
Well, no. I mean, when you and I went, when you said when you were well enough, you wanted to go to, and you weren't really well enough, because the same as everybody with ME, is that they push themselves to the very limits, and I've been holding it back as much as I can. So you got in touch with your MP, who was then became a minister.
This was the Right Honourable Ben Wallace, the ex-Defence Minister.
Yeah. And you told her about my work, and you said you need to meet Dr. Perrin and get Dr. Perrin's work more accepted. So we went down to London, the two of us, and met Ben Wallace at the House of Commons, and he assured us he'll try his best to get this work out there.
And in respect to him, I have to say, it was 3 months later, after that particular meeting, after he heard all about your work, he gave us a good 2 hours of his time, ordinarily just 1. And after that, he pushed as hard as he could to get the health minister and the head of NICE, and he literally did everything in his powers to help the NICE guidelines to change. And he wrote then 3 months later back to me and said they're now going to change those NICE guidelines, and it then took a consequential few years before it was all finalized. But am I right, there was still some kickback from psychologists? Is that correct?
Oh yeah, there's I mean, I was at the original NICE meeting where they did actually say we're going to rip up the old guidelines and start again. Yeah. And pace the dreaded graded exercise program, exercise training, the GET, that was going to be taken out, and anything based on the psychology side of things, wasn't going to be advised as a specific. I mean, as an adjunct maybe, but not as a major part of the treatment. But it wasn't. They acknowledged that graded exercise had caused problems and major problems for a lot of patients. So that was really exciting. We were invited to hand over to them any evidence, and we did. They ignored virtually everything I sent them, unfortunately, because the diagnostic study was not on. We had an alternative diagnosis rather than going through symptoms and history. We said that we have an adjunct to the diagnosis, and you can look at all the symptoms and all the history you want, but having the physical signs as well really emphasizes that the person has got ME. And that's what we wanted to say. It's not a standalone diagnosis, but together with the history and with the symptoms, it's very, very highly accurate diagnostic signs. And we asked them to look at it, but I was told by somebody who was in the committee that they didn't actually spend time at all on my diagnostics.
So why do you think they didn't take time to look at your work, Ray?
Well, I think it's a matter of I don't think, basically, I mean, being a bit controversial, I don't think they want to give me much credibility for my work, because once they acknowledge that my diagnostic signs have validity and the physical signs have validity, then you can, and then there's people will start looking and saying, what about the treatment? It's got a treatment program, and then that will have more validity. And I will say this publicly, and I've said this to a lot of patients, quite a few years ago, I was paid by the NHS to train up a whole group of physiotherapists in Manchester, in their clinic in Manchester. So I trained them to do the techniques, and we had a clinic who was going to open using my techniques. This was going well over, I was saying, about 15 years ago or even more. And we had a rheumatologist who was going to work with us and make sure that he screened the patients for other things, consultant, and we had a patient ready to go through, and she went to the consultant and then went off to the clinic and found it was being closed. So they no sooner had opened this and closed it again, so without seeing one patient. And I found out from the head of the clinic, they said, well, we got a notification from upstairs from some pen pusher saying, we don't want to open the floodgates, do we?
That's very interesting.
So this was then. Now it has changed a lot. We've just finished an NHS research study, which was overseen by the NHS. We found the funds for it because I've not been funded at all by the government to do any of my research. We've just raised funds from patients, but we've done a study looking at looking at the treatment, self-massage treatment, and it was sponsored. It was overseen by the NHS. So they are changing the tune. We did the diagnostic study was done in NHS hospitals as well. They were supporting us then. So there's a turn from the earlier days, and I think the NHS are looking into my work, especially for long COVID, because they've got nothing else to offer. But the diagnostics should be included in all clinics. Treatment-wise, it just takes longer, but I'm not a drug, and that's the thing. So it's not going to make major profits for anybody sort of saying that my treatment should help, but it's going to save a lot of hours and
lives, Ray. I want to say quite literally, Ray, that your treatment has saved my life and my partner, Mark Singleton, as well. It has been a contributing factor to our overall recovery of health. Obviously, we've in particular in my case, I've had to look at diet and meditation and all the hybrid of other holistic modalities, but the through line, the spine quite literally, of my recovery has been your treatment, and that is undeniable. And that is why it is so important that this podcast is heard, because a lot of people don't have access to your treatment. I know in my personal campaigning over the years of your work, I wanted your treatment to be accessible to the masses on the NHS, etc. And that way you could save us so many more lives. And that is what it should be, in my heart and in my opinion. Everybody should have the chance, and you once said this, to recover from any chronic illness for free. And that is what should be happening. A patient shouldn't have to lose money, stop work, and all these other things. I mean, I have to say, I was forced to stop work, and looking back, if I hadn't been as severe as I was, would I have stopped? And then would the treatment have worked? And possibly not, because it's symbiotic with rest, something that ME patients don't understand the meaning of. And I don't think you do. And you always said if you ever got ME, you would really struggle, because you and I have the same
I'd be
personality.
my worst patient ever, Cathy.
What was that?
I'd be my worst patient ever.
Why is that, Ray?
No, because I'm saying, because I would to pace oneself, because pacing is so important.
But I think the most important thing to hear as a clinician is that from an ME perspective, we haven't got a choice. And I knew back in 2014 when I collapsed, I led in bed, I prayed, I looked up, and I said, whoever saves my life, please bring someone to save my life. It took another 2 years of living. It was like being crushed with a concrete slab and set on fire. And no matter what limitations and bits I did, I then crashed after. And without you, there's no way I'd be sat here talking to you today. And there's just no way. So even though I'm not fully recovered, and I'm still, sadly, I have comorbidities, and that is absolutely one of the reasons I'm not fully better. And as you said, I may never be, but I am certainly better than I was, because that was unlivable, my symptomology back in the beginning. So I've come to you for the best part of 9 years, and the best part of 8 of those was almost every single week. So I want to encourage somebody that just because my situation was so extreme, in fact, in spite of that, don't hold back and think it's going to take that length of time. I've just been extremely unlucky with 99 out of 100 symptoms. I didn't have depression. That was the one symptom I didn't have. I had POTS, vestibular damage, you name it, I had it. And therefore, the majority of those symptoms, they are so much less than they were. And I want you to also explain now about the SLIM, the SLYM, which was the Copenhagen studies.
Right. Okay. So I said we now know the drainage of the brain exists, the lymphatic system. But as I said, that when we stimulate the drainage and get the toxins moving, you think that patients will recover fully, all of them. Why not? Once you got the toxins out, that's it. But so I always said, well, in lots of cases, new toxins are coming back in all the time. You're draining out some, and new ones are coming back in. And the thing is that when the toxins have come in again, then you have to drain them out. So I wasn't happy with that, because okay, there's some patients that do recover, that we do get completely better. So how are we getting some people better and some people not? So in some people they were getting permanent relief, and the drainage system worked again. So that was always a bit of a question mark until last year, because last year there was a new development. They discovered the existence of a new membrane of the brain. The membranes of the brain are the meninges, the dura, the arachnoid, and the pia, the 3 meninges, the 3 membranes of the brain. When they get infected, inflamed, that's what meningitis is. So those meninges have always been there, and there's been a space between the arachnoid and the pia called the subarachnoid space, and that space contains cerebrospinal fluid. So we always presume that as a drain of the toxins, cerebrospinal fluid from the subarachnoid space replaces what the toxins have drained away through the lymphatic system now. And we now know it's not exactly like that, because the SLIM is a one cell thick membrane, mostly one cell thick, very, very small, going right through this subarachnoid space, dividing the fluids. So the outer side of the subarachnoid space, the SLIM, which stands for the subarachnoid lymphatic-like membrane, because it's lymphatic-like, it lets the small molecules in, but not the big ones. So big toxins won't be able to get back into the brain. And inside the SLIM, in the subarachnoid space, is healthy, clear cerebrospinal fluid. So this clear one is going into the brain, and toxins are coming out and going to the outer side, which then drain out through this lymphatic drainage system that we now know exists. And the SLIM actually is so small, it can easily get traumatized. So any trauma, and it's all around the brain and down the spinal cord as well. The subarachnoid space goes right down to the bottom of the spine, called the sacrum. Goes right down to the sacrum. And this subarachnoid lymphatic-like membrane goes down with it, and it will stop any large molecules coming in again if it works. But if there's damage, if there's inflammation or trauma from the past, and more damage, then there's more likelihood of the drainage coming out, but then going straight back in again, or the larger molecules coming out and going back in again.
And when you say trauma, you mean physical trauma?
Physical trauma, yeah, but also, I mean, emotional trauma and chemical trauma as well, but a lot of physical trauma will damage the SLIM. If you have infections, it could build up infections, can build up chemicals on the SLIM that could damage the SLIM as well. If it's overloaded, similar to different parts of the brain, you could easily get toxic damage of.
Would you say that medicines could affect that?
Medicines could definitely affect it as well, but it depends which medicines you have. But the main cause is probably physical strain or physical trauma to the spine and physical trauma to the head. And then you've got also major infections that will lead to a lot of inflammatory, infectious toxins building up on the SLIM and could damage it that way as well. So those are the main two.
So causes. Toxins, what you're saying is the shape of the skull and the spine is number one. Then you've got the toxins from either emotional, which creates neurotoxins, physical or chemical, all a hybrid of different toxins, all entering the brain and potentially causing this damage. Is that correct?
Yes. Yeah. Yes.
I have written a book, so luckily I'm not a neuroscientist, but Ruby Wax and myself are the only two stand-up comedians, I think, that understand neuroscience. No, the great thing is, Ray, you have a treatment. I would really love you to share what that treatment involves and what it's about and what the patient can expect when they come to you.
Right. So the treatment is based on osteopathic techniques plus a few extra techniques that I've picked up over the years, and I've developed a treatment that is manual lymphatic drainage of the body, especially of the back and the cranial the cranium, the head, and it's the drainage system by massaging and opening the spine, and by doing cranial techniques and lymphatic drainage, we create what I call the concertina effect, pushing down and pushing up. So it's gentle treatment that pushes this pressure there, which eventually leads to the drainage of the poisons, and not so and of all the poisons would eventually lead to health. But we're talking about this technique starts as soon as we start the treatment. It's very gentle, but it has a major effect. Some patients are astounded how powerful a few bits of massage can be, but it's pushing the toxins out into the bloodstream the way it should be, rather than going backwards up into the head and going downwards around the body. So we're creating this concertina effect. Also in some countries they call it the accordion or harmonica effect. So creating this pressure. Now, once that happens, it pushes out, creating another scientific effect, because the pressure changes from outside to in is very similar to the siphon effect. And the siphon effect is like, when you suck up the rubbish of the bottom of a fish pond, a fish tank, and then you put it into a bucket and it just carries on flowing. Once you've created this pressure differential, then it continues flowing, and that's what we do. We create this pressure differential and then we keep it going. Patients do self-massage as well, and it's pushing all the toxins up and down in the front, and we do up and down in the back, and we do cranial, and that's basically the Perrin technique, the manual side of it.
Wow. And what can patients expect when they come to see you, Ray? From my experience, and my brain wasn't working, so I've gone on a lot of information from others and limited memory. But I do know that I met you and you were extremely kind-hearted. You sat there behind a desk and you took a history of information. And then I sat on a couch, I think, led on a couch, and you did, you held my skull. And in my personal case, you actually said, your skull is so inflamed, I can't believe you're smiling. So if I'm an extreme case, then there has to be hope for others, because there is mild, moderate, severe, and in my case was very severe, but there are other levels of this condition. And am I right in saying if you catch it early enough, then you've got the best chances and the fastest chances of recovery?
Yeah, absolutely no question about it. The quicker, the better. And this is, I mean, even the guidance for ME has changed over the years. They used to say 6 months before they diagnose it, then they went to 3 months, and now they say it doesn't have to be 3 months if you use your clinical judgment. Now, according to the international consensus criteria, just using practitioner judgment. If the practitioner is experienced enough, they can diagnose before the 3 months.
So what I love about your work is that you don't say this is the only way to get better. What you say is it's a jigsaw piece.
So it's a jigsaw puzzle analogy
that
I talk about. That ME is not just going to be helped. Sometimes patients do recover with just my treatment, but often they need other things. But the first thing I tell patients, they've got to rest. Then also they've got to relax. And the relaxation doesn't mean I'm relaxing because Dr. Perrin told me to relax. It means actually chillaxing. And if you can't do that, then learn how to meditate, because meditation's a very good form of relaxation, breath works, whatever. And then the last one, and the most important, is one of pacing. Half of what you feel capable of doing. Now, these form the corners of a jigsaw puzzle. That analogy that I use, the jigsaw puzzle, as you know, any jigsaw puzzle is made much easier if you get the corners first, then the edge pieces, and then seeing the sky in the middle. So the corners are rest, relaxation, meditation, and pacing. The edge pieces are the Perrin technique itself, where actually we work on the neurolymphatic system and get everything draining better. And then the seeing the sky is all the other things, like maybe talking therapy, maybe so there's
Diet.
there's nutrition, there's supplementation. There's a lot. Nutrition and diet is very important. A lot of other modalities are very that can help the patient improve. Are part of the seeing the sky. So, but it's the corners first: the rest, relaxation, meditation, and pacing that are the most important. And the edge pieces, the Perrin technique, are the second most important. and then other things on top. And you're talking about toxins. I mean, you were one of my worst cases. The worst case ever I saw was a patient who's just recently able to be strong enough to actually come to the clinic for the first time. But for years I've been treating her at home, and she couldn't tolerate even pen. That she could only react to write on the notes with pencil because the ink of the pen, the chemicals that she could detect when we came into the room with the pen were too much for her. But she is, thankfully she's recovered to the point where she's back, getting out a bit more now, and where she was very, very severely ill with ME.
And the thing is, I didn't meet you when I first collapsed, so my case was, to the audience, extreme. Very extreme. I couldn't turn my head on a pillow. I had all those sensitivities, blackout curtains, ear defenders, and even doing anything at all, I had to crawl, and it would take me hours. And then obviously you'd then be in bed and you couldn't move. So I understand that extremity level, which not everybody does.
No.
Therefore, my story has to be heard, because what you have done has transformed my life, and I would not be here, I'm sure you agree, without you. Would you agree with that?
Well, you were in a very bad state when I saw you, and there have been people who their body eventually shuts down totally. I don't want to be doom and gloom merchant, but some people can die as a result of ME.
Yeah.
And I've seen that, unfortunately, when the toxins have been so bad we can't change that.
And in my case, Antoinette has also been on the podcast, and she works at your clinic, and she described, having not known me as you do, she described doing one treatment with me, just a standard, basic, very gentle effleurage, and I had to be carried out. And you saw that as well. I looked like the dentist in the Little Shop of Horrors. And you used to say, stop laughing, but asking me to stop laughing is like asking you to stop working. It's impossible. So basically the extremities of the reaction, and I think you've also said that as well, you've not seen a reaction to your treatment to its extremity as in my body, but it just shows, as a 7-stone woman, how much toxicity had accumulated in the whole system. And you also, for me personally, you drain the limbs as well. Just explain what you've had to do, as well as the ear work.
You say about the drainage of the body. The drainage it's so important to drain off the toxins in the rest of the body as well. You can get muscle fatigue due to buildup of lactic acid, and that's very common with ME. But as I said, with the analogy that we use, the jigsaw puzzle analogy, you can try different things, and if things don't work or you can't tolerate them, then don't do it. But the main things are the rest, relaxation, meditation, pacing, and the Perrin technique are the main guidance to really get the patient better as well as possible. And when you come to intolerances and you can't cope with different drugs, then that's part of the jigsaw puzzle. You have to adapt and have to change, because you can't.
And food intolerance as well. When I first collapsed, I couldn't eat anything, fruit, anything. It literally was stinging. And what in my case I had was blood clots that had accumulated in the gut, and that was why. So the Perrin technique has had to, if you like, drain blood clots out. That's when it goes to an extreme level.
Well, this is why I said the pathogenesis for this and long COVID are the same. And that's why you can see there's very great levels of patients with all sorts of problems, very similar to what we're just talking about now, what you've had. And that's very common symptoms.
And it's therefore, with one could question whether they are, and I know Dr. Nigel Spate's been on and he's also raised that question, could they be the same? But he felt that there may be additional symptomology in the long COVID patients, and I put forward that I had additional symptomology, having had carbon monoxide poisoning as well.
There's lots of extra things as well with long COVID that does affect the lungs more, and and you get more fibrotic tissue formation in different
Yeah.
areas of the lung. But we know why that's happening as well, because what should drain off the fibroblasts that cause fibrotic tissue, and that's the lymphatic system.
So
What
it's
have I
the same
said?
cause of the problem. So in long COVID and ME, there is an overlap. Do you think in time it could be that it's exactly the same thing, Ray?
Well, yes, I think that basically that in most cases it is. There are extra, as you say, Nigel Spate said, that there are other symptoms in long COVID that we don't see too much in ME. And I'd agree that there's more fibrotic tissue formation, and you get fibrotic organs, and you get the blood clotting. You do get that with ME as well, and you get this as we're seeing this with the long COVID patients as well. But
Yeah.
there is a definite overlap, and you're seeing the very similar symptoms. Yeah.
And what I want to say is, had I come to you as a little girl, I would probably have had I'd have definitely had a better, healthier life. I've had 25 years of tonsillitis, and I've never had tonsillitis since your treatment.
Hopefully, with the treatment, you've drained off enough toxins that they're not affecting you as badly anymore, and therefore they're not building up.
What I'm finding, Ray, is when I have a bit of sugar in my diet as well, or a poor diet, which I discussed with another clinician, I do find that I start to have some of the symptoms. So could it be that our diet, sugar, as well as medication, all these things?
Yeah, absolutely, because sugar stimulates the production of yeast, which is candida. Then you've got gluten as well, and you've got and then you've got casein in the milk protein. So they're all irritants for these conditions. Well, what's going on? Why them? Because they're all large molecules, and therefore there's too much of them. They need to be drained away by the lymph. And if they're not drained away by the lymph and they stay there, even if there's not too much of them, they all need to be drained away by the lymph. And the lymph in the gut is very important for draining off fat. So you get fatty deposits in places, and you get people with lymphedema and lipedema when you've got these problems. That's the fat. And they found there's fibrotic tissue and fatty tissue in ME patients and in long COVID patients. They've actually identified this now, and this is the reason why they have it. A lot of women get endometriosis with ME, and that's another comorbidity, because what's happened there, the endometrial tissue from the womb has to be drained away by the lymph.
And is that because, Ray,
it just builds up everywhere.
Is it, just to explain, is that because the lymph is back flowing and dual flowing in ME?
Yes.
So the blood is basically going up and down. Is that correct?
Whooshing forwards and backwards, exactly. Rather than just stopped. If it stopped completely, it would just every balloon out, you'll all get lymphedema. It's not stopping, it's draining and draining backwards, draining and draining backwards, draining and draining backwards. And that's because the overall control mechanism of the sympathetic nervous system is the hypothalamus. That's the balance mechanism. And that's being poisoned, and that's being affected. And there's even one area of the hypothalamus that we know what's going wrong. It's called the paraventricular nucleus, and this is a very important part. The PVN of the hypothalamus is an incredibly important part of the things going wrong, and that's where we'll be doing research in the future into this.
Thank you very much. And I also want to add that what would you, if a patient was presenting, Ray, what signs should people look for, particularly for children who maybe can't express themselves as well? And would you agree that children can get ME? That's important.
Yes, absolutely. I've seen patients as young as 5 with ME.
If somebody was presenting with symptoms, what symptoms would they be?
Well, first of all, there'd be a change in the overall pattern of the person. There'd be usually a great lot of physical and a mental fatigue. It can affect the cognitive side. It'll be post-exertion malaise. It'll be post-exertion, so it doesn't actually happen at the exertion. It could be up to 3 days afterwards. It doesn't have to be straight away. there'd be problems in their head, lots of headaches, the sleep problems. This would be a major factor because we now know that major drainage of the brain happens during delta wave sleep, deep sleep. And this is not, and these patients aren't getting that. So they don't get the drainage and they wake up the next day unrefreshed. So waking up in the morning unrefreshed, even though you had a long sleep, is also a sign, because that long sleep wouldn't include much deep waves, delta waves. And we've written a single case study on the long COVID patient with exactly this problem, where they're not getting much delta waves, but with the treatment, they're changed very quickly from the deep sleep to the improved sleep.
And what's
So
the
they had
difference?
much more deep sleep. So they had much better sleep, and better deep sleep meant better drainage, and that improved the symptoms. And we've shown this in this case study.
Because that's important to add. The drainage of the brain occurs during sleep. That's what people need to understand.
Yeah.
And in Emmy, it's switched so that we're sleeping in the daytime instead of at night, because and that's what we call crashes. We call them brain crashes. And I was having, 50, 60 a day. I mean, I literally would crawl and crash. And so the most important thing as well that I want to add is stay in bed, because I think my journey was absolutely elongated, and I think Mark Singleton, my partner, felt the same, that our journey was a lot longer had we done what the master had told us to do. So when you said, Cathy, you can cut one bush in the garden and you can chop that and then put the cutters down and go and rest, I couldn't just do one thing. I couldn't stop, not wouldn't stop. And I think that my whole system had got so cranked. There was so much chemicals, because even you were surprised. So the point is the level of toxicity that you could not, you're a genius, but how could you possibly know how much toxicity was in?
There's 100 billion neurons in the brain, 100 billion, and they're all connected by synapses. So there's trillions of synapses, and those synapses can be affected by neurotoxins. And there's 100,000 neurotoxins that could affect you, affecting trillions of different connections, the synapses. How the hell can you ever know what the symptoms are and what chemicals are and what the problem is in the brain? Everybody's different. Everybody.
And that's it.
Why everybody is.
And that's exactly it, Ray, that when people come to you, the average is 1 to 3 years of the treatment, 3 years being your predicted worst case scenarios. And sometimes those people need to continue. But in my case, it was 8 years of almost every single week, because the whole system, I mean, I pushed myself.
And also the slim was damaged, probably,
and the slim in the brain damage,
and therefore we're getting more as we drain off. It comes back, a lot of it comes back.
That's it. And I think there was congestion in with the blood clots in my tummy that have come out, and I also have a tumor that doubled in size in 2020. These blockages, and the gallbladder doesn't work. I know you've said in women in particular, for anyone listening today, women often have gallbladder issues, secondary gallbladder issues, liver like I have, I go yellow, and you do a liver pump, which is just phenomenal. I mean, how many people out there do a physical liver pump where you pump my liver and suddenly it's the release and relief is just unbelievable of pain. So because my symptoms, because my system has been so damaged from birth, and I'm 50 this year, so we're talking 50 years of a mass of different high levels of toxins, which, without having ME would have potentially caused damage, but with having secondary ME, those toxins were just building up and building up. 10 years before I met you, I said to my GP, I feel a pressure on the top of my skull. It's like my brain has expanded. I said, I know that sounds silly, but it feels like my brain's about to come through the top of my head. I distinctly remember saying that, and I was working on stage and I had 3 businesses. I was high flying entertainer, never rested. my rest time was a Zumba class. And it's important that people understand that now I rest. Now I pace under your guidance. Now, because you've removed so much toxicity, Ray, I don't have that adrenalized system whereby I can't stop. I actually, I'm able to pace because I believe it was the toxins causing this maelstrom of reactions. Would you agree with that?
I would agree with everything you said. Yeah, absolutely.
And so eventually, as the toxins are cleared through your treatment, which in most cases will not take as long as me.
It sounds for people watching, oh, I don't want years of treatment, but as I said, you the worst case. I mean, often it can take a few months, sometimes less. Some patients get better very quickly, and some patients get completely better, and some patients struggle. But by a year we should see some improvement, and then some people might be much better within 6 months, and some people might even be better 3. So we work out a score to give a prognosis of the patient based on the history, based on the symptoms, based on comorbidities, and how long they've had it for, and how they've coped with it, and what they've done, what treatment. All these are factored in to a final score where we give them an idea out of 10 how well they are.
I also wanted to add how hypermobile Ehlers-Danlos syndrome, which I call all these diseases disease states, because your treatment has alleviated all these disease states. So the vestibular damage, where the tubes were almost constricted, by your realignment of the jaw and your treatment, that opened up all those that system, and of course the drainage started to work, and I actually bled at my inner ears. They started to bleed and drain blood out, which shows it was just all constricted.
No, there's lymphatics everywhere in the body. Everywhere there's blood there's lymph, and so we know that now there's lymph in the brain and the spinal cord, anywhere there's blood. But there's also lymph nodes, which are which collect a whole load of T cells and B cells, which are the immune cells that the lymphocytes. And during when you have an infection, the lymph nodes will be there to help as the journey of these toxins goes along the lymph. They break down the toxins a bit, and it goes to another area where they break down more, eventually going into the subclavian vessels there. The neck has the largest amount of 200 to 300 lymphatic lymph nodes, rather than, so the neck has the most of all there's around, could be 600 to 800 lymph nodes in the body. A large amount of them are in the neck. And
could that explain tonsillitis, Ray, to the layperson? Because a lot of patients
tonsils aren't lymph nodes, but they're lymph nodules. They're lymph nodules, so they're very similar. And then a lot of toxins are coming out all the time into this area. It will affect the tonsils, and you get a lot of patients with tonsillitis, and a lot of patients have had the tonsils removed when they're younger. So there's compromise. If your tonsils are working, you need them. But if they're not working properly because of the buildup of toxins, they sometimes do need to be removed as well. But that's
important, because mine went black. So what you're saying is the constriction of the drainage of the lymphatic and the glymphatic, the drainage of the brain, the drainage of the whole system, as this buildup of toxins continues and is left untreated for a length of time. That is why symptomology can worsen, and that's why I collapsed bedbound. I didn't just suddenly get it. It had been a build-up of toxicity. Is that correct?
Yeah, the build-up of toxins everywhere.
So really what I want to end with is to say, if you can diagnose potentially in children, is there a way that you could diagnose in children early so that you could pick up factors in adulthood?
Well, I'm the only person in the world that says you can prevent ME, prevent these conditions, because the physical signs are there before the symptoms. So if you've got people in the family, and sometimes it's familial, sometimes it's genetic, that you have in the family, just like you look like your parents because of gene factors, you inside the cranium could be very similar without you knowing it, on the spine as well. We see a lot of spinal problems in families. So there's a familial link to these conditions that you can actually see, and therefore in some patients who have the illness, some of them haven't developed it fully yet, but the physical signs are there.
The last thing was the pale skin. Obviously, I have colour in my cheeks today, thanks to you, but I was always very anemic white, and I know you explained that reason. Just explain.
Well, no, I mean the anemia. There's the pale is because of blood flow. Lots of times the sympathetic nerves aren't working properly, so it affects the blood flow. So you don't get rosy cheeks, you get very pale. But it's actually interesting. There's a new study just done out now looking at lymph, that the genes that produce lymph vessels are also there to produce red blood cells. So there's a new study just came out last year looking at the cause of the lymph, the cause of anemia, as you talked about, could be very much related to the lymphatics.
So the blood flow, how does it affect the blood flow?
The blood flow. Well, the sympathetic nervous system affects the blood flow because it controls the blood vessel walls, and there's a major control of the heart. So it can affect, as going back to Da Costa, irritable heart, it can affect the heart, and you can have problems, and it can cause problems in the blood. But there's a new study just came out this last year, which looks at a very interesting genetic study showing that the gene expression needed for the vessels of lymphatic vessels, the gene that is responsible for the production of lymph vessel walls, is also the same gene that produces red blood cells.
Wow.
So the theory is that actually red blood cells are being produced within the lymphatic system as well as the bone marrow. So as well as the bone marrow. So this would be fascinating to know that people with these conditions, lymphatics, can affect red blood cells and can cause anemia and cause sticky blood in some cases, the opposite.
Right.
And so all sorts of things can happen, and it needs further research. I think it's just a new discovery, but it's very interesting.
Thank you very much, Ray. Well, I'm sad to have to close today because there is so much. You have a wealth of understanding and knowledge. How can people find you, Ray, or Dr. Perrin? How can people find you, please?
I think just speak to you. You send them to me. You send it. Just get in touch with Cathy, and she'll tell you exactly how to get in touch with me. No.
I tell the postman. I tell everybody.
And we'll just...
So how can people find you, Ray, should they want to come for treatment?
Right. Besides going through you, Cathy, they can look on the website, www.theperrintechnique.com, and on it there's a map which shows all the Perrin Technique practitioners that are licensed, who have trained. So you might not need to see me. You can go to see one of the nearer practitioners. We have a group practice in my group of practitioners in my clinic in Manchester. So you don't need to see me. They're all trained to do the technique, but around the world we're getting more and more, and soon going to America to train up maybe up to 100 practitioners around the States in just 1 month.
Fantastic. Well, I just want to say, whereabouts are you? Where is your clinic as well, please?
It's
Ray?
in Prestwich in Manchester, North Manchester. So,
and it's called the Perrin Clinic.
The Perrin Clinic, and it's 83 Whitaker Lane, Prestwich, and the phone number is 0161 7730123 if you want to come to our clinic. But look on the web and you might find a clinic much closer to yours with a licensed practitioner there who I've trained personally, so they should be able to help you.
That is absolutely fantastic, Ray. Absolutely incredible to have you on today as well. A mind of consistent information, a wealth of skills, and a wonderful, kind-hearted humanitarian to boot. So honestly, it's been
my head's grown too big.
Just like mine did.
It's going up there.
It's been an absolute pleasure having you on today, Ray. Thank you
Thanks,
so much for sharing all this science with me. And not just that, I'll see you in 2 days for my treatment. But thank you for all you've done for me and for my partner, Mark Singleton. Right. And I wish you all the very best ahead. And I hope that one day your treatment can be available to the masses. And what's your last words in support of the ME community, Ray?
So don't give up. The one thing is that patients do sometimes give up, and I say don't. There's more research. We're doing more research. We've got a new centre being set up, and we're going to be doing much more research to find out the ME patients. Some of them have more than just ME, and they need to be looked at as well. And you might need more than just one treatment. My treatment might not be the only thing that can help. We can't promise a cure, but we promise to help in some way, and we usually can. If we can't help, we'll hopefully refer patients on to somebody who can, if possible.
That's incredible. Well, Dr. Raymond Perrin, thank you so much for your time today.
Thank you very much, Cathy, and thank you very much, Tinker, for being such a good dog and not disturbing you. She's still there. He's
enjoyed every minute. So many thanks from both of us today. Okay. Have a wonderful day, and thank you so much for your time. Thank you.
Take care. God bless. Bye-bye.
You too. Bye-bye.